Hello, I'm Erwin Lerner, Chief Executive Officer of Hoffman Roche Incorporated. Hoffman Roche is proud of its commitment to original research in biology, chemistry, and biotechnology, and the dedication of its research people who every day search for new treatment modalities across a broad therapeutic front. Our efforts include basic research in the fields of oncology, infectious diseases, cardiovascular and central nervous system disorders, nutrition, and the new frontier of biotechnology. Our commitment is ongoing, long-standing, and remains unwavering in the quest to provide you, the physician, with the tools needed to control and conquer disease. Roche's basic research investment now exceeds $2 million every working day in this search. While I'm confident that these efforts will bear the fruits of new therapies, this success must then be clearly, concisely, and accurately communicated. No new compound or new treatment modality is meaningful until you, the clinician, understand and know how to appropriately incorporate it as a part of your basic treatment armamentarium. Therefore, we also pledge to commit all of our resources necessary to make sure that we remain a leader in effectively communicating with you. We hope you'll welcome our highly trained representatives, as well as continue to benefit from timely information on existing as well as new Roche products via all appropriate media. We believe our best research partner is the well-informed physician making the right therapeutic decision for his patient and, when appropriate, using our products with optimal knowledge. Thank you.
This is the Video Journal of Medicine, your televised report on current developments within the profession that affect your practice today. In this issue, you'll see convincing scientific evidence of the effectiveness of the Center for Disease Control's precautions in preventing blood-borne infections, guidelines for successful pharmacologic therapy for geriatric patients, and an update on total joint replacement. The Video Journal of Medicine is made possible through the support of Roche Laboratories, innovators in medical research, dedicated to continuing education. And now, our lead report on the Video Journal of Medicine, Preventing Blood-Borne Infections in the Healthcare Setting, presented by Dr. David Henderson, Associate Director and Hospital Epidemiologist, Clinical Center, National Institutes of Health in Bethesda, Maryland.
In response to significant anxiety on the part of healthcare workers who feared contracting AIDS from patients, in 1982, the United States Centers for Disease Control issued the first set of guidelines designed to minimize the risk of occupational exposures to the human immunodeficiency virus, the virus that causes AIDS. These first recommendations were modeled after those for the prevention of hepatitis B virus transmission, since the epidemiology of AIDS in the community, although still unknown at that time, seemed to be similar to the epidemiology of hepatitis B infection in the community as well. These guidelines were updated in 1983, summarized in 1987, and updated again in 1988. Here's a brief summary of these CDC recommendations. Hands should be washed before and after patient contact, and immediately if contaminated with blood or other body fluids. Hands should also be washed after removing gloves. Gloves should be worn if soiling of the hands with blood or other blood-containing body fluids is likely. Although masks are usually not needed, they should be worn in combination with protective eyewear when splashing or splattering of blood or other body fluids is likely. Gowns are not routinely needed, but should be worn if soiling of exposed skin or clothing is likely. Contaminated needles and other sharp disposable objects should never be bent, clipped, or recapped. Rather, they should be discarded in a puncture-resistant container immediately after their use. These containers should never be overfilled. They should be closed, sealed, and discarded when they are 2/3 to 3/4 full. Contaminated reusable equipment should be cleaned of visible organic material, placed in an impervious container, and returned to central hospital supply for decontamination and reprocessing. Pocket masks or mechanical ventilation devices should be readily available in areas where resuscitation procedures are likely to be needed. Gloves and other barriers should always be used when cleaning spills of blood or other body fluids. Excess material should be wiped up with disposable towels or other absorbent materials. After the area is cleaned with soap and water, it should then be disinfected with a dilute solution of household bleach and water. This solution should never be more than 24 hours old. Large spills, or spills containing broken glass or sharp objects, should first be covered with disposable towels and then saturated with bleach solution and allowed to stand for 10 minutes. Then they should be cleaned as previously described. Finally, healthcare workers who have open lesions on their hands or skin should not participate in direct patient care activities or handle contaminated equipment. These individuals should be evaluated by the hospital's employee health service or by their own personal physicians to determine fitness for duty. The healthcare employer is responsible for compliance with these precautions and should provide orientation, training, and continuing education, as well as adequate barrier supplies for all healthcare workers. Because employers are required to monitor compliance with universal precautions, it's important that they develop procedures for counseling and retraining non-compliant employees and for disciplining repeatedly non-compliant employees as well. The most important revision in the CDC's guidelines was seen in the August 1987 update. This change regards universal blood and body fluid precautions and is now simply referred to as universal precautions. The recommendations now stress that all patients should be assumed to be infectious for HIV and/or other bloodborne pathogens. Adherence to universal precautions is required when healthcare workers are exposed to blood, certain other body fluids, and any other body fluid visibly contaminated with blood. Universal precautions do not apply for exposure to other body fluids, for example, feces, nasal secretions, sputum, sweat, tears, urine, or vomitus, unless these fluids are visibly contaminated with blood, since these are not documented routes of transmission for HIV. Despite the establishment of these universal precautions, occupational HIV-1 exposure and seroconversion does occur. Although the risk of occupational HIV infection is low when compared to the risk for transmission or infection with the hepatitis B virus, it's still too high a risk to take. The risk of HIV transmission to healthcare workers via percutaneous or parenteral exposure is approximately 0.4%, a rate of roughly 4 infections for every 1,000 exposures. However, to date, there have been no documented HIV-related deaths among healthcare workers sustaining these exposures. For comparison, out of 1,000 occupational exposures to the hepatitis B virus, approximately 230 to 430 healthcare workers will be infected with this virus. Although all exposures may not result in symptomatic hepatitis B infection, the Occupational Safety and Health Administration conservatively estimates that there will be about 200 hepatitis B-related deaths following occupational exposures to healthcare workers in the United States each year. Let's quickly review some studies that looked at transmission of bloodborne infection. The CDC Cooperative Needle Stick Surveillance Group study revealed that a significant percentage of the 1,201 occupational exposures to HIV that occurred in this study were preventable. Specifically, 37% of the exposures attributed to recapping needles, improper disposal, and open wound contamination were categorized as preventable. CDC scientists concluded that the risk for HIV infection after documented exposure to the blood of a patient infected with HIV is low. However, the need for compliance with recommended infection control precautions to prevent exposures cannot be overemphasized. Despite continuing concern on the part of healthcare workers about occupational HIV exposures, compliance with CDC infection control precautions is by no means universal. A prospective study conducted by Dr. Julie Gerberding at San Francisco General Hospital revealed that 46% of physicians, 61% of nurses, and 67% of other healthcare professionals used inadequate infection control precautions when treating patients with AIDS. A study conducted at the Johns Hopkins University emergency room revealed that healthcare providers adopted universal precautions during only 44% of emergency interventions. Even more troubling was the percentage decrease to 19.5% when these workers were caring for patients who were bleeding profusely, the exact situation where universal precautions should be most closely adhered to. In fact, a large number of the participants reported that they were still recapping discarded needles, the most common mode of occupational injury to healthcare workers. Several things need to be done in order to reduce the healthcare workers' risk for exposures to HIV and hepatitis B virus. First, universal precautions should be thoughtfully implemented and followed. Existing staff should be retrained regarding the risks of contracting HIV in the healthcare workplace. Studies conducted at the NIH have found that compliance increases when employees have a clear perception of the actual risk of being infected with the virus, as opposed to simply being educated about how the virus is transmitted. Procedures associated with inherent risk need to be modified to reduce the risk of infection. For example, during the course of some pelvic procedures, some gynecologists blindly palpate in the pelvis for the tip of the needle. This procedure is almost certainly associated with an increased level of risk of sustaining a needle stick injury, and certainly is associated with an increased risk for occupational exposure to bloodborne pathogens. Procedures such as these need to be modified to reduce these risks. I also believe that the curricula of medical and nursing schools, as well as other healthcare training programs, should be altered to include bottom-line information about risks, beginning with vaccination against hepatitis B virus and continuing with new infectious diseases, including HIV, as we continue to learn about them. In addition, technological developments, for example, self-blending needles, could ultimately make the healthcare workplace safer. Manufacturers of dangerous devices should be requested and encouraged to develop safer products. Dr. Janine Jagger from the University of Virginia demonstrated that a substantial percentage of occupational exposures could be attributed to medical technology. In other words, technological improvements, specifically improvements in instrument and device design, could minimize the risk for some types of occupational exposures. The development of effective post-exposure chemoprophylaxis is another mechanism for minimizing the risk for these occupational infections. Historically, however, antiviral agents have played a limited role in chemoprophylaxis. We'll discuss this issue in more detail in a few moments. Finally, an effective vaccine against HIV needs to be developed. Ongoing research in this field is progressing, and we hope will reach fruition soon. However, in order to be effective, a vaccine must be administered prior to exposure. Historically, medicine and science have dealt with most viral infections by vaccine development. Research on a safe and effective vaccine is ongoing at several laboratories here and overseas. Using the published CDC recommendations as a framework, each institution should develop a systematic approach to the management of occupational exposures to blood or blood-containing body fluids. A clear definition for exposure needs to be established. Although each incident should be considered individually, the institution should provide guidance regarding which general types of injuries require further evaluation. Injuries of the types listed here should be reported to the employee's supervisor and/or to the employee health service as soon as possible. Assuming that baseline blood samples for testing for HIV and HBV were obtained, additional samples should be drawn from the recipient at 6 weeks, 12 weeks, 6 months, and 1 year following exposure. The employee should also be counseled to report for further evaluation if he or she develops associated symptoms. The value of the 1-year follow-up specimen is not yet known, and therefore is not included in the current CDC recommendations. However, because of the concern regarding the period of time that elapses between HIV exposure and infection, the 1-year blood sample may be advisable. The issue of whether zidovudine should be offered to healthcare workers who have been exposed to HIV-1 infected blood or body fluids remains controversial, primarily because the safety and efficacy of the drug in this setting have not yet been demonstrated. Animal studies have shown that zidovudine has at least some effect against HIV. However, it's difficult to extrapolate from animal trials to the human situation. Although zidovudine is not documented to be effective prophylactically, it's presently the only drug licensed to treat HIV infection. Additionally, it has demonstrated some effect in virtually every situation in which it's been tried against HIV. However, until definitive scientific data on post-exposure AZT chemoprophylaxis are available, decisions about its use in this setting will have to be made on an individual basis. Healthcare workers may elect to develop an institution-wide approach to this difficult issue. The management of HIV-1 infected healthcare workers presents formidable problems for healthcare organizations. The seemingly reasonable and practical case-by-case management approach recommended by CDC since 1985 can often be difficult to implement. Of paramount concern is how to make administrative decisions about an employee with AIDS while adequately safeguarding confidentiality and respecting his or her rights. In the absence of definitive data on HIV, a common-sense approach to management of an HIV-infected employee in the same manner as employees who have other medical problems would seem advisable.
The Video Journal of Medicine is made possible through the support of Roche Laboratories.
Gastroesophageal reflux disease is one of the most common complaints seen by the practicing physician. While heartburn is its most usual manifestation, reflux can sometimes present with unusual symptoms that complicate diagnosis. Fortunately, treatment with H2 antagonists can help many of these patients.
Gastroesophageal reflux may have an entire spectrum of action. You may have the individual who has occasional heartburn, or you may have the individual who develops severe peptic esophagitis with stricture formation. It is estimated that at least 10% of the population have gastroesophageal reflux symptoms at some times. Not all those patients require intensive therapy. The difficult area is to identify those individuals that will require more intensive therapy, and then to determine how long they should be on that therapy.
Non-cardiac chest pain can be a manifestation not of heart disease, but actually acid reflux. Secondly, we're aware now that there are a number of ear, nose, and throat problems, such as hoarseness, fullness in the throat, coughing sensation, maybe the result of acid reflux.
Studies indicate that reflux may be present in up to 65% of adult asthmatics. Reflux in the asthmatic may be exacerbated by such medications as theophylline, which may decrease lower esophageal sphincter pressure. Also, asthmatic coughing or wheezing can lead to reflux by producing swings in the abdominothoracic pressure. And reflux itself may precipitate coughing.
It's been difficult for us to document it, though if you take a group of people with this unresponsive steroid-dependent asthma and you do 24-hour pH studies, that is, put a pH electrode right above the lower portion of the esophagus, upwards to about 60% of them will have acid reflux. That does not necessarily mean that the acid's going all the way up in the back of their throat and they're aspirating it. But in our laboratory and in the laboratory of Steve Sontag's in Chicago, we both have studies that this may occur.
Today, many patients with GERD can be treated successfully with H2 antagonists.
The therapeutic approach that I take bases on the symptoms and the severity of the damage to the esophagus. Saying that, the primary therapy for all patients is what we call simple lifestyle modifications. Unfortunately, they're simple, but sometimes we as physicians don't emphasize them enough. But that will include things like decreasing your weight if you're overweight, decreasing or stopping smoking, not eating large meals before you retire, eating smaller meals, watching the foods that you eat. There are certain foods which actually decrease lower esophageal sphincter pressure, like chocolate. There's other foods which are direct irritants on the esophagus, such as citrus products or tomato-based products. Those need to be avoided. And there's a number of medications that people take which may actually aggravate esophageal problems. If patients are having more problems, just mild symptomatic disease without any esophageal damage, then you can treat these patients with antacids or Gaviscon. Saying that, these drugs may not be much more effective than placebo at taking care of the symptoms. If the patients have more severe symptoms, and particularly if they're having esophagitis damage, then I think we have to go what we call phase 2 therapy, and the cornerstone to phase 2 therapy is the H2 blockers.
After 11 years' experience with the H2 antagonists, only one such agent, Zantac, is indicated for relief of heartburn pain. The recommended dose is 150 milligrams twice daily.
Next on the Video Journal of Medicine, complications of pharmacologic therapy for geriatric patients with Dr. John Collins Harvey, Professor Emeritus of Medicine and Geriatrics and Senior Scholar in Ethics, Kennedy Institute of Ethics at Georgetown University.
Drug therapy in the elderly, a population with a disproportionately high instance of disease and chronic illness, is complicated by many factors unique to this age group. Individualized pharmacologic therapy for geriatric patients must be based on several considerations, including pharmacodynamic and pharmacokinetic changes, frequency of drug interactions, and toxicities and degree of patient compliance. With people surviving to older ages in increasing numbers and accounting for a major proportion of prescription drug use, clinicians must be alert to the goals and consequences of drug therapy in elderly patients. Age-dependent physiological changes can significantly alter drug absorption, distribution, metabolism, and excretion. Pharmacokinetic and pharmacodynamic considerations, supplemented by clinically relevant information and good clinical judgment, therefore play an important role in treating geriatric patients. Physiological changes in the elderly can affect the delivery and effect of a drug at its site of action. Age-dependent changes in body composition, serum albumin and globulin concentrations, cardiac output and hepatic and renal blood flow, and hepatic and renal cellular functional changes all can alter pharmacokinetics. Decreased gastric acidity, delayed gastric emptying, changes in intestinal motility, reduced gastrointestinal blood flow, and impairment of active transport mechanisms are age-related variables that influence absorption of orally administered drugs. Alterations in drug distribution can be attributed to several age-dependent variables, including decreases in lean body mass, total body water, cardiac output, and albumin levels in the serum. As a patient ages, body fat increases at the expense of lean mass, with a concomitant increase in the ratio of fat to water. The volume of distribution of water-soluble drugs, therefore, decreases because of this increase in fat-water ratio. In contrast, fat-soluble drugs such as phenytoin, benzodiazepines, and barbiturates have a greater volume of distribution because of this change in ratio. The extent to which drugs are bound to albumin is another important variable which may influence the volume of distribution of a drug. The plasma concentration level is a measure of both the bound and unbound or active drug. Drugs like Coumadin and Dilantin, often used in treating the elderly, are tightly bound, about 98%, to albumin. Hypoproteinemia, which often occurs in elderly persons, can result in decreased protein binding in this population. If the levels of albumin decrease even slightly with aging, then the amount of activity for a drug like Coumadin in the blood can be doubled. Therefore, a given dose of a drug administered to a 65-year-old patient will yield a greater free fraction of drug, or more free drug in the plasma, than the same dose administered to a 25-year-old subject. So in fact, normal concentrations of a drug often represent in elderly patients a very high level of unbound drug that may actually be toxic. For this reason, measurement of the plasma-free drug concentration can be a more accurate guide for dosage requirements in the elderly than the level of the total concentration in the plasma. Drug metabolism, for which the liver plays a central role, can also be altered by age-dependent anatomical and physiological changes. In advanced age, the weight of the liver diminishes and deposits of the age pigment lipofucsin increase in hepatic cells. The amount of scleroprotein also increases, as does the rate of cellular destruction. Increased polyploid cell populations, decreased cellular enzymes, cellular chromosome alterations, and mitochondrial changes in the hepatic cells are also common. Impaired hepatic metabolism prolongs the drug's half-life, which delays the development of the steady state. Therefore, for a given plasma concentration, there will be a delayed therapeutic as well as a delayed toxic effect in elderly patients. Even if the drug is stopped because of decreased clearance due to impaired hepatic or renal function, the same drug effect will be seen because of this delay in the development of the steady state. The half-life of amitriptyline, a very common tricyclic antidepressant, is from 16 to 40 hours. The dose in an adult where the half-life is only 16 hours is 100 to 300 milligrams per day. However, in the elderly, we would adjust the dose downward to 25 milligrams and at most upwards only to 150 milligrams because of this difference in half-life. This same thing occurs with the neuroleptic drugs. Traxine, a benzodiazepine compound, has a half-life of 200 hours. The dose for elderly patients, therefore, must also be adjusted downward. Excretion of drugs by the kidneys can be altered by age-related decreases in glomerular and tubular cell function. Creatinine clearance, which is a measurement of pure glomerular function, can decrease significantly in elderly patients. Despite decreases in lean body mass in the elderly, the creatinine level in the serum remains the same, since the ratios for reduction in lean body mass where production of creatinine takes place and in renal creatinine clearance are the same. Physicians who use creatinine level in the serum as a measure of renal function in elderly patients, therefore, are using a very false value. In light of the age-related pharmacokinetic and pharmacodynamic changes, physicians need to consider the following questions when prescribing for elderly patients. What is the basic diagnosis? What are the defects in normal physiology? What is the rational therapy for this particular patient, and does it include drug therapy? What are the reasonable therapeutic expectations from the use of the drug? How can improvement based upon the drug therapy be assessed, and how long will the drug treatment be used? What is the appropriate dosage of the drug based on the altered pharmacokinetics? And finally, what are the potential adverse effects of the drugs? In order to develop a rational treatment strategy for geriatric patients, physicians must be knowledgeable of common drug-drug interactions. Here, the clinical pharmacologist comes in as an essential co-worker. Well, Ms. Miles, good to see you this afternoon.
Nice to see you.
Now, you
too.
brought your medicines in as I asked you the last time we saw each other,
Yeah.
so I could see what you're taking. I know you don't like to take pills, but you got a whole bag full. Let me see what you've been taking here.
What for?
What for? Right. Okay, all right, that. It is also essential that physicians know what other drugs the patient is currently taking. The brown bag test is helpful. Before their initial visit and at each subsequent visit, patients should be asked to clear out their medicine chest of any drugs that they have been taking. This is where the problem of polypharmacy becomes evident. It is not uncommon for patients to bring in 8, 10, 12, or even 14 bottles of different medications.
I have a heck of a time to sleep.
Well, now you were taking some pills for that. Elderly patients often ask for medication to help them sleep. However, every one of these soporific drugs has adverse side effects. Here it is helpful to understand the sleep pattern in the elderly. Ms. Miles, you're having trouble with sleep, but you're only entitled to about 6 hours of sleep per 24-hour period. Do you know what that means? If you sleep 2 hours in the afternoon before that television up in your room, you're only entitled to 4 hours more sleep. That means if you go to bed at midnight, you're going to be wide awake at 4 o'clock in the morning. Patient noncompliance, which can be attributed to many factors, can complicate drug therapy in the elderly. If the doctor does not consider the effects of the altered physiology when prescribing medication, an adverse therapeutic outcome can cause the patient to stop taking the medication. The patient simply will believe that the drug isn't working, or perhaps that it is causing a worsening of the illness. Increased instance and severity of disease and multiple complaints of symptoms by the patient can lead a physician to believe that additional medications are needed. However, increased usage of drugs increases the potential for drug-drug interactions, which may cause adverse effects. The same result can occur. The patient stops taking the medication. Noncompliance can also be attributed to decreased mental acuity in elderly patients. Unrecognized depression, mild dementia, and sight and hearing problems can limit a patient's ability to understand what the doctor has prescribed. Moreover, infant and child-proof containers developed for prescription drug safety purposes often cannot be opened by elderly patients who have osteoarthritis, which particularly affects grip by the thumb and rotary thrust of the hand. Economics may also be a factor in noncompliance. Many of the elderly with decreased income simply cannot afford to buy medications. Thus, it is not uncommon for prescriptions to remain unfilled. Because of the likelihood of multiple illnesses, the higher risk of adverse drug reactions, and the increased potential for compliance problems, greater attention to detail and individualization is needed when prescribing for geriatric patients. Some general guidelines should be observed. Take extra time to obtain a complete drug history, which provides an opportunity to learn all of the patient's current medications. Well, now, you know, as I've been telling you, your blood pressure is up, and we've got to deal with that. But the reason it's really up is because you're a little bit overweight. Now, use alternatives to drug therapy whenever possible. Common examples of this are weight control for diabetes rather than the oral diabetic drugs, weight control for hypertension rather than diuretics, increased fiber and liquid intake for constipation rather than laxatives, and psychotherapy or support groups for reactive depression rather than the immediate use of antidepressants. Determine a realistic treatment goal. Although drugs should not be withheld if treatment will improve the patient's condition, the ratio of risk to benefits needs to be assessed on an ongoing basis. Be thoroughly familiar with the pharmacokinetics of drugs you prescribe for elderly patients. Knowledge of a drug's actions and side effects and of age-related physiological changes will help you to prescribe safely and effectively. Individualized therapy. The variation in drug response increases with age. Be certain that the drug and dose is appropriate for a particular patient with a particular disease or condition. Be a therapeutic conservative. Use smaller doses and adjust the dosage downward as necessary to the patient's clinical response. Consider the patient's condition, size, and weight, as well as the drug properties. Simplify the drug regimen. Try to eliminate all medications that are not absolutely essential. Where possible, consolidate or reduce the number of doses. For example, it is more convenient and easier for a patient to remember to take a single pill of 200 milligrams of oral drug once daily than a pill of 50 milligrams of oral drug 4 times a day. Monitor the patient for drug-related symptoms. In the absence or presence of new symptomatology, particularly when a drug is prescribed or discontinued, always suspect that the drug may be the cause of the symptoms. Review drug therapy periodically. Chronic care means constantly changing care. Take a new look at old prescriptions every 3 months and determine whether these medications are still needed and if the dosage is appropriate. Discourage the use of non-prescription medications for common complaints. Many of these medications can cause more problems than they solve.
The Video Journal of Medicine is made possible through the support of Roche Laboratories. Once a day, Rocephin, ceftriaxone sodium Roche, is effective in serious bacterial infections caused by susceptible organisms. Rocephin once a day is generally well tolerated. There are no reports of definite association between ceftriaxone and adverse hematologic or nephrotoxic events. In the hospital, once-a-day treatment means significant cost savings. Also true for outpatient therapy. Rocephin, ceftriaxone sodium Roche. Effective, safe, convenient, economical, once a day. Please note that for pediatric patients, a BID dosage schedule is recommended. A pamphlet containing full product information, which includes a list of adverse reactions, is located in the case for this video cassette. If it's missing, please contact your Roche representative, who will be happy to provide additional copies. Next on the Video Journal of Medicine, Update, Total Joint Replacement, with Dr. Richard Laskin, Professor of Orthopedic Surgery at the State University of New York at Stony Brook and Chairman of the Department of Orthopedic Surgery at Long Island Jewish Medical Center in New Hyde Park, New York.
When an arthritis patient suffers severe pain which does not respond to conservative treatment, surgical replacement of the affected joint may be indicated. The results of properly performed cemented total knee and hip arthroplasties have been excellent. One major unresolved problem, however, does remain, namely the long-term loosening of the implants and the resulting need for revision surgery. This center has been evaluating cementless joint prostheses with the view towards reducing the revision rate, as well as making revision arthroplasty, when necessary, a less complicated procedure. The primary indication for all total joint replacement is intractable pain caused by advanced arthritis. Stiffness alone sometimes justifies replacement, especially when more than one joint is involved. In my practice, osteoarthritis and rheumatoid arthritis make up 90% of the patients requiring arthroplasty. The remaining 10% have less common types of arthritis, such as post-traumatic arthritis, arthritis secondary to chronic bowel disease, avascular necrosis, or ankylosing spondylitis. The patient population is evenly divided between males and females. The average patient undergoing a total joint replacement is usually in the late 50s, 60s, or 70s. Occasionally, we will see patients in their 40s or younger who need artificial joints. These patients usually have some type of severe generalized arthritis, mainly of the rheumatoid etiology. Probably 90% of arthritis patients do not ever need a joint replacement. Those who do have been unresponsive to conservative therapies, such as analgesics, nonsteroidal anti-inflammatory drugs, and physical therapy. They are patients in whom pain is severely limiting their ability to participate in the activities of daily living. Very often they've been forced into an early retirement or to a sedentary means of existence. When we talk about total joint replacement, we're usually referring to hips and knees. Although some new artificial shoulder designs show promise, I believe it will probably be 2 or 3 more years before we see shoulder replacement performed on a routine basis. Unfortunately, replacement of the ankle and elbow joints has not met with success and is rarely done at this time. In addition to the general contraindications for any surgery, there are specific contraindications for knee and hip replacement. In most situations, these include prior septic arthritis in the joint, neuropathic arthropathy, and poor skin or vascular condition in the extremity. In knees specifically, a prior arthrodesis would be a contraindication for a total joint replacement. This is not true in the hip, however. All hip and knee prostheses are made of both metal and plastic. The basic concept is to form a low-friction bearing surface between the components in order to allow free motion and to minimize the stress on the implant-bone interface. Early in the 1970s, the metal that was used was stainless steel. Since that time, we have progressed to cobalt chrome alloy, and most recently, to titanium alloy and aluminum oxide ceramic. The plastic that we use is a high-density polyethylene. The coefficient of friction of this plastic against any of these metals is extremely low. During total hip surgery, we normally approach the hip posterolaterally. We open the capsule and dislocate the hip posteriorly. Next, we cut off the femoral head and expose the acetabulum. We ream the acetabulum of any remaining cartilage. The femoral intermedullary canal is enlarged with a broach and then thoroughly cleansed with brushes and with a water pick type of pulsatile lavage. The femoral canal and acetabulum are then dried. For cemented implants, we then mix the liquid monomer and powdered polymer of polymethyl methacrylate, or PMMA, and when they are partially set, inject them into the acetabular bed. The permanent acetabular implant is inserted and held until the cement cures. A similar procedure is performed on the femoral side using a cement gun to deliver the cement into the femoral canal. After all the cement has cured, the hip is reduced and the wound is closed. It should be noted that the two components of the total hip joint are not articulated. In vivo, they are held together and the joint made stable by the action of the hip musculature, primarily the hip abductors. During total knee replacement surgery, we approach the knee anteriorly and dislocate the patella laterally. The surgery is usually performed with a pneumatic tourniquet in place to minimize bleeding. We remove a thin segment of bone from the distal femur and a similar small segment from the proximal tibia and undersurfaces of the patella. For cemented total knee replacements, we mix the PMMA as we did in the total hip procedure and inject it into the cut surfaces of the femur, tibia, and patella. The permanent implants are then impacted into position and held until the cement cures. As in the hip, the total knee prosthesis is not articulated. Knee stability is achieved by ligament and muscle tension. It should be noted that during a total knee replacement, we take care to protect the medial and lateral collateral ligaments in order to ensure this postoperative stability. The cruciate ligaments, however, can be sacrificed and antero-posterior stability still obtained through the configuration of the surface of the implant. The results of properly performed cemented total hip and knee replacements have been excellent, and more than 85% of the patients have complete relief of pain. These postoperative x-rays show the position of a properly fitted total knee replacement. Besides the usual risks of surgery, and in addition to infection, which I'll discuss in a moment, the risks of arthroplasty are those of any leg surgery. Foremost is thromboembolic disease, which affects about 1% of these patients. Consequently, most arthroplasty patients are on anticoagulation medications. There is always a chance of the bone being fractured or of nerve or vascular damage during surgery, but these are very rare. The most serious complication of a prosthetic joint replacement is infection. Often, infected prostheses must be removed and then cannot be replaced for months, if at all. That means protracted hospitalization and persistent physical disability. Fortunately, improvements in the operating room environment have resulted in an 8-fold reduction in the incidence of infection as compared to those rates that we saw in the early 1970s. Most large centers doing total joint replacements are now using laminar flow rooms, in which the patient is isolated in a chamber into which filtered air is introduced in parallel jets. This reduces the possibility of stirring up eddies and dust from the floor. Operating room personnel also wear body exhaust suits, which again isolate the patient from the surgical team. In addition, the patient is given parenteral antibiotics during surgery. 2 very big studies, one in Scandinavia and one here in the United States, looked at total hip and knee replacements done in a variety of operating room environments. The studies showed a 5% infection rate in a standard operating room with the patient not receiving parenteral antibiotics. With the laminar flow room, the infection rate was reduced to 2.5%. Using body exhaust suits, the rate of infection came down to about 1%. And given parenteral antibiotics as well, the rate was cut down to 0.5%. The rate in our medical center is just below 0.5%. The major long-term complication of total joint replacement is the loosening of the implants from the bone. It has been estimated that every individual takes about 1,200,000 steps each year. That's 1,200,000 times the leg is jarred each time it's placed on the ground. Given enough time, the best prosthetic joint is going to loosen from the bone. If that happens, a patient who has been pain-free for many years will begin to complain of pain again. This recurrent pain can be an indication for revision joint surgery. Several studies have shown a revision rate of 50% after 10 years using earlier designs of prostheses. Although newer designs and improved surgical techniques have cut that rate approximately by 2/3, revision surgery still remains a potential risk for any patient undergoing a total joint replacement. Normally, the revision procedure is a longer and more complex operation than the primary arthroplasty. A hip revision, for example, can take 3 to 4 hours, about twice the time of the initial operation. We have to spend a large percentage of our time in revision surgery drilling and picking out the old cement. There's also a fair amount of blood loss and a higher rate of infection. It's for these reasons that uncemented prosthetic joints offer the possibility of making the revision operation much simpler and less problematical for the patient. To implant an uncemented total joint, one needs an immediate press fit of the implant on the bone for initial stability. This press fit is obtained by accurate bone cuts, supplemented at times by screws or pegs on the implant. The surface of the implant which comes into contact with the bone is porous, and it is this porous surface which acts as a substrate for tissue ingrowth. With time, such ingrowth further stabilizes the implant. The implant that we have been studying for uncemented use in the knee is called the Tricon M. It makes use of flanged polyethylene fixation pegs affixed to each of the components for initial interference fit. During surgery, these fixation pegs are impacted into appropriately sized holes drilled into the tibia, femur, and patella. The flanges lock the pegs into place and stabilize the component. Cement is not needed. The undersides of the Tricon M joint components are coated with sintered cobalt chrome beads, forming pores of about 100 to 250 microns in diameter. Pores of this size have been shown to allow tissue ingrowth within 12 to 14 weeks. Other investigators are using prostheses which, instead of covered with beads, are covered with short filaments of wire, again providing pores as a medium for bony ingrowth. We have had some retrieval specimens from deceased patients and from others who have suffered later leg injuries and have found tissue ingrowth in some of these patients, but not all of them. One Tricon M tibial component, in place for 1 year and 6 months, was removed at another institution after the patient had suffered a medial collateral ligament tear. The implant was removed, the ligament repaired, and a more constrained implant inserted. The femoral component showed bony ingrowth to a depth of 1 millimeter into approximately 75% of the pores on the distal surface. There was also tissue ingrowth into about 25% of the pores of the tibial component. The decision whether or not to use an uncemented implant is reserved until the operation has begun. The major contraindications for uncemented devices are patients in whom a tight wedge fit is not possible, and those whose bones are very osteoporotic. Those may include patients who have been on steroids for many years, elderly women who have not used calcium supplementation at any time during their lives, and rheumatoid arthritis patients who have severe periarticular osteoporosis. For these patients, a cemented joint will be selected. I have gone back to revise some of the uncemented total knees, some of which had loosened and some of which were injured accidentally. As we had hoped, revision of an uncemented joint was a much less complex procedure. Once the old component was out, the new one was implanted almost immediately, so there was a tremendous saving in surgical time. More important, however, there was no chipping and cutting away of cement and adherent bone. We have recently compared 91 Tricon M uncemented knees with a like number of randomly selected Richard's Maximum Contact, or RMC knees. These were computer paired for similar age decade, diagnosis, and weight category. The pairs were compared as to component position, range of motion, pain, walking ability, stability, extensor leg, flexion contracture, and patient satisfaction. The results show that the Tricon M knee uncemented and the cemented total knees were statistically similar in all parameters. At the 2-year evaluation, 85% of both the uncemented and cemented patients reported that they were completely pain-free. Early in our study, we were finding out that at about 6 weeks, the uncemented knees were causing slightly more pain than the cemented knees. We assumed this was a natural phenomenon, that somehow the uncemented knee had to settle in place. We have learned, however, that what we were doing was undersizing the implants. We found that with exactly the right-sized implant, there was no pain at 6 weeks. I've now compared 6-week data on my last 200 uncemented knees with 200 cemented knees I had done previously, and there is no difference at all in reported pain. When uncemented joints were first being developed, there was some thought that there would be a decreased risk of infection with them as compared to cemented joints, but we have not been able to demonstrate that. As for a reduction in the rate of revision surgery, we are hopeful that the tissue ingrowth we're seeing in these uncemented joints will provide the pain-free stability that we're seeking for many years. Regardless of whether the patient has a cemented or an uncemented joint, physical rehabilitation is required, and usually it begins 1 or 2 days post-surgically. For knee replacements, the rehabilitation involves range of motion in addition to muscle strengthening exercises. We usually recommend the use of a CPM machine which gradually bends and straightens the knees at a very slow rate. The angle of flexion can be programmed, and we usually start at about 30 degrees, increasing by 10 degrees each day. My patients use the machine for several hours a day. They also receive gait training and participate in muscle strengthening exercises. After release from the hospital, knee patients must continue with home physical therapy to continue developing range of motion and strength. For hip patients, extensive physical therapy is usually not required, although there will still be some exercises to build up the hip muscles. For both hip and knee patients, I allow them to be up the day after surgery. By the second day, they can be bearing some weight on the leg using support in both hands for balance, either crutches or 2 canes. I continue them with that support for 6 weeks, and then with 1 cane for 6 more weeks. Total joint replacement has proven to be a useful therapy for arthritis patients for whom conservative treatment is no longer effective. It should be reserved for those patients whose quality of life has diminished substantially due to intractable pain. After complete recovery, most arthroplasty patients walk without a cane and can participate in most non-impact sports, that is, activities such as golf, swimming, walking, bicycle riding, and climbing. The development of uncemented prostheses improves the outlook for patients in need of revision therapy and may eventually significantly reduce the overall need for joint revisions. It is likely that in the future, uncemented hips and knees will be the standard for total joint replacement, but cemented joints will still be necessary for patients with osteoporosis.
The Video Journal of Medicine is made possible through the support of Roche Laboratories.
For better sedation during endoscopy, take a closer look at Versed instead of diazepam.
I didn't think there was a drug with advantages over diazepam, but now I use Versed. In my opinion, diazepam doesn't compare.
Let's look at the differences in dosing Versed. Versed is 3 to 4 times as potent per milligram as diazepam. To achieve conscious sedation, it should never be administered rapidly or as a bolus. Start low. The Versed 1 milligram per milliliter concentration facilitates titration.
It's easier to inject slowly and individualize the dose. Some patients respond to as little as 1 milligram. Initially, never give more than 2.5 milligrams over a 2-minute period. Wait 2 minutes to evaluate effect. If needed, titrate with small increments and wait 2 minutes to evaluate.
14, 13.
We're titrating to the sedative endpoint of initiation of slurred speech.
9, 8, 7.
Sounds like she's ready.
For superior IV conscious sedation, Versed, it's worth a closer look. IV Versed has been associated with respiratory depression and respiratory arrest, especially when used for conscious sedation. In some cases, where this was not recognized promptly and treated effectively, death or hypoxic encephalopathy has resulted. Provide for continuous monitoring of respiratory and cardiac function. Immediate availability of resuscitative drugs and equipment and personnel trained in their use should be assured. Caution patients about driving or operating hazardous machinery. See complete product information.
The Video Journal of Medicine is made possible through the support of Roche Laboratories, innovators in medical research dedicated to continuing education.